and I want to thank first the Society of Cardiology for the invitation. I hope I will look good on the video. So, as you know, every session is video streamed, and I've been told to tell you that it will be possible to access it on the homepage. Now, which cardiac patient cannot be anticoagulated? This is a strange picture. I will explain it in the further slides. And the worst case scenario that happened to us this year was an 81-year-old man with an actively oozing bleeding from angiodysplasia in the transverse and descending colon. He had 4 red blood cell transfusions. He had a nadir of his hemoglobin, which was 50. And in his past history, we knew that he was first on Marcumar. That didn't work because of his INR that was difficult to regulate. He had Xarelto then, Pradaxa, and finally because of his other cardiologic history of peripheral arterial occlusive disease on his right leg, he had also clopidogrel, and he had aspirin that was stopped finally. So as we have heard in the lunch session, triple therapy was not very healthy for this man, and we did first APC and epinephrine, and this was not very effective. Even he was on PPI in the antrum. He had then injections of epinephrine and clipping, and a persisting bleeding on twofold clipping again. So the solution of this case was what will be one of the next talks. It was a percutaneous closure of his atrial appendage with a 30 millimeter cardiac plaque. So we needed a cardiologist, and the cardiologist needed us. These are some pictures. You can see clipping in the colon. It looks like that if it's not bleeding, but it may also look like that. This is a cancer in the stomach. You can clip it, but it will still bleed. And here definitely oral anticoagulation is not a good choice. In the duodenum, you can have on triple therapy ulcers, and then you might have the only solution. That's the first picture we have seen. That's hemospray. That's a powder of minerals that does a very good job on hemostasis, and which is used a lot. Now to the stigmata. What's our daily work in endoscopy? Here you see the high-risk ulcers with a spurting vessel. Here you see a visible vessel, and here you see an adherent clot. And the risk of rebleeding is corresponding to the classification of Forrest. Now, if you don't treat, you will have a rebleeding rate up to 100%. For the spurting vessel, you will go up to 50 for the visible, and for the clot, 35. So these 3 are the most risky cases you should be aware of. And if you treat them, the recurrent bleeding risk will drop down to 10%. So we have done in 2002 a study with the CHUV in St. Gallen, and we have seen that the risk of rebleeding with usual injection therapy is still high, and if you add fibrin to epinephrine, it's not really better. There was some tendency that spurting vessels were treated a little bit better due to compression. But what is new on the field now, as you see in this meta-analysis, is that combination therapy provides a much better treatment and results, and clips are probably better than thermal therapies. So if in this systemic review, you can obviously see that all endoscopic therapies decrease rebleeding compared to pharmacotherapy, and the optimal therapy is a combination of either clip or thermal therapy. So we need you, and you need us. And the practice points is, how do we treat bleedings? Is we do the hemodynamic risk assessment first. We look at the stigmata when we endoscope. We provide endoscopic therapy to our patients. We provide adrenal injections and combine it with a second modality according to the presentation of the bleeding. And then we will treat them usually, if possible, with hemostatic clips that are very effective and provide a mechanical prevention of recurrent bleeding. And if in risk situations, we will also apply intravenous proton pump inhibitors if it's an upper GI bleeding. Now, this is an algorithm that shows us that high-risk ulcers are treated with endoscopic therapy to prevent recurrent bleeding. And if recurrent bleeding occurs, you have still the choice of an embolization or surgery. Embolization has been one of the most promising evolutions in bleeding therapies, and we use it a lot at our hospital. So we are coming now to the aggregation inhibition and anticoagulation. One of the landmark studies by Sung was to show that continuous aspirin therapy may increase the recurrent bleeding rates, but potentially reduces mortality. And this was shown in this nice paper, which showed that cardiovascular complications were much more frequent if aspirin was discontinued, and those patients who had a continuation of aspirin had less mortality, and this is shown on this slide, showing that the aspirin continuation had a lower mortality rate of different conditions, and GI bleeding was not significantly different between the two groups. The other thing is warfarin. Actually, warfarin is the classical anticoagulation, and there are retrospective cohort studies. This one is from Colorado, showing that there was not a really difference between the sites of bleeding according to mortality, and the death was related to the discontinuation of warfarin, and the death rate was lowest when warfarin was resumed. Not really early, if I can say that, but when it was resumed at all, because people used to stop warfarin completely. So here you see the 11 events of thromboembolic events in this cohort study. 3 were fatal, and those 3 that were fatal were patients with atrial fibrillation and stroke, and not bleeding. So the 90 days thrombosis on continued warfarin was significantly lower, and the recurrent GI bleeding was not significantly different between the two groups. And the patients with warfarin-associated GI bleeding continued antithrombotic therapy in the first week if possible. For warfarin, we can say thus that thromboembolism and mortality can be lowered. We should resume warfarin, but we don't know the optimal duration until this last study was published, showing that the warfarin reinitiated early in the after GI bleeding stopped is more efficient than the later introduction of warfarin or the not reinitiation at all. No increase of recurrent GI bleeding in patients who early initiated warfarin. What's new about triple therapy? This is a wonderful study by D. Wild showing that if you omit aspirin, you will have a lowering of GI bleeding from 8.8 to 2.9%. And thus, clopidogrel without aspirin is the right way to go, and reduction in bleeding complications without increasing the rate of thromboembolic events. So anticoagulation, atrial fibrillation with NOACs might be also something promising, but we know that although there is superior safety and efficacy, we have no antagonists available if we have bleeding, and the management is still not as easy because of renal and other interactions with this drug. And some trials have shown clearly that NOACs have more risk of bleeding, major GI bleedings, than Warfarin. But if we look at it more precisely, it was published in the Gastrointestinal 2013, we see that especially for patients with acute coronary syndrome and patients on dabigatran, the risk is more elevated. So we should maybe watch out for the right patient groups and select the right anticoagulation for them. The Hasbled risk score is something everybody has read about, has some advantages, but still it differentiates only with abnormal renal liver function and bleeding history from the CHED score, and the 1 year risk for major bleeding should be in this cohort, should be predictable by the Hasbled score. Just to illustrate, you see that the higher the Hasbled score goes, the higher the bleeding rates. And I will show you the overlapping of the stroke risk scores and the bleeding risk scores. As you see, the age hypertension is all over, and that's why the overlapping is so high, and it's difficult to really apply it in practice. So if the Hasbled score exceeds largely or importantly the CHED2 score, anticoagulation should be reflected more. That's maybe the main message. You have to always take the Hasbled score in comparison to the CHED score. And there are no robust prospective studies that have shown any benefit of withholding anticoagulation on the basis of a high bleeding score. So summary and conclusion. High-risk patients with endoscopic therapy have 10 to 24% recurrent bleeding. Thermal coagulation therapy and hemostatic clips are effective in reducing bleeding and the need of surgery. Low risk of mortality and thromboembolism is associated with earlier reinitiation of oral anticoagulation. Omitting triple therapy in patients with atrial fibrillation and PCI decreases GI bleeding risk considerably. And there are no robust prospective studies, and we need them. So I thank you for your attention. Thank you very much.
Thank you, Professor Borovicka, for this very nice talk. Are there some questions? Yes, please.
I have a question with regards to recurrence of GI bleed after GI bleed. Whether there are any predictors, whether you can tell us the problem is solved and we can restart anticoagulation, or the problem is most likely not solved and we have to look for some alternative option, as you've shown before, such as left atrial appendage occlusion. So are there predictors for recurrence of GI bleed?
So the forest is, as you might think, is quite a root predictor. But I think if your clipping is efficient and the mechanical clipping holds through, or you embolize it transarterially something, and then you see there is no bleeding anymore, and it doesn't depend only on the adrenaline injections you have done before, then you have quite a good prediction that it will stay calm. But if you're not sure, you should return and look. You should do a second look maybe. So there are a few indications for second looks, but this might be one then. Yeah.